keep in touch. So this is time. Welcome to the first event of the King's Philosophy and Medicine Colloquium that's taking place on the Guys campus. So welcome. I'm not going to go on and on about it. It's just a project that's trying to have medics and philosophers talk about issues that are of mutual interest, that they're already talking about in their own communities. So basically, I think as long as you can get medics and philosophers in the same room, all I need to do is press start, and anything, conversation will begin. So tonight we have Steve John, who's a philosopher at the University of Cambridge in the History and Philosophy of Science department, and he's going to talk about lies, damn lies, and statistics, and he can do the rest. Oh, we should take this opportunity to shut off all of our beeping devices because we're recording. Just I didn't do the microphone, but from now on, we're coming.
Okay, great. Thank you very much, Eric, and thank you for the invitation. Thank you to you all for coming. I find this microphone slightly disconcerting, but I'm sure I'll get used to it. So just to explain, I hope everyone has a handout. Normally, when I speak, I never use PowerPoint. I only ever use handouts. But I've learned from experience, bitter experience, if you try to speak to people with a medical background and don't use PowerPoint, it kind of often goes horribly wrong. So I apologise in advance if my PowerPoint is less than professional. The choice to use the handout, to use the slides, is kind of ironic and interesting because precisely what I want to talk about today is communication. So we have a lot of work on medical ethics and kind of increasingly political philosophy and healthcare issues, so-called public health ethics. We have a lot of work, well, increasing amounts of work on the philosophy of science and the philosophy of medicine as they relate. What I'm interested in is a topic which in a way is between the two. Philosophical issues around communication. So part of what I want to do today is talk about cancer risk specifically. Part of what I want to do is just sell you a bigger program, a bigger project. But before doing a kind of bigger project, let me just give you an example. So here's my example. Here's my case. So imagine we've got Jane. She's a 55-year-old woman who receives a letter from the NHS inviting her to a mammography. So regular screening as we have in the UK. Why do we screen women who are at 55? Well, roughly because the 10-year breast cancer risk in that group is around 3%. Okay? Now imagine that Jane the previous day read a news report, and in the newspaper it said women who had a particular family history, her family history, are in fact at a 7% risk of breast cancer. She's very worried about this. She goes to speak to a friend of hers who's an epidemiologist. The epidemiologist says, Jane, don't worry. Remember the research on breastfeeding. Okay? You breastfed 2 children for 2 years. Among women like you, the rate of breast cancer, it's only something like 1.5%. The numbers here are also made up to make it dramatic as possible. Okay? But these are representative kinds of numbers. What am I going to do in this talk? First thing I want to do, I just want to assume that those numbers represent true population frequencies. Okay? I mean, you might worry, of course, about the kind of transferring the epidemiological findings to a new population. Put those worries to one side. Assume these represent good population level statistics. Second thing you might say is, well, we've got to be careful here because the causal links are unknown. Put all questions of causation to one side. Yeah? Because for purposes of prediction, for purposes of knowing your risk, you don't have to know the causes, you just have to know the indicators. The indicators might be causally related to what you care about. But in and of itself, it doesn't really matter if breastfeeding is strictly a cause, or in this case a preventative, going against breast cancer or not. All it matters is correlation. Poor Jane, she's bombarded with this information. So what does Jane do? She's confused. At 7%, mammography seems worth the risk. 1.5%, mammography has side effects. She's a busy woman, takes some time off work. She's worried about false positive. It doesn't seem worth it. At 3%, it's on the edge. So Jane's confused. She goes to her GP and she says, look, what's my risk of breast cancer? What should the GP say? Should the GP give her risk qua age? I've got some handouts. Should the GP give her risk qua age and family history? Or should the GP give her risk qua age and breastfeeding history? Or maybe her risk qua age, family history, and breastfeeding history, and so on. Which risk estimate should the GP give? That's the question I want to talk about today. Now, before I go any further, two things whenever I give a talk on this topic. The first response I get to people is, that's too complicated. Don't worry, GPs don't face that problem because they've got guidelines which tell them what to do. Response two, that's too simplistic. In real life, GPs don't just say you breastfed or not. They have these really complicated models and really complicated systems for figuring out what to tell an individual their breast cancer risk is. But of course, note that while the example is deliberately simplistic, there's a question here, or it's deliberately, in a way, too complex. What should the guidelines say? Yeah? Presumably, the guidelines have to be based on something. And an obvious way of understanding what the guidelines should be based on is what the GP in the clinic should tell Jane, roughly, in this kind of example. Yeah? So it's a way of getting to what the guidelines should be. What I say later will complicate this bit. It's too simplistic. Sure, of course, in a clinic we use complex models to generate estimates of breast cancer risk. But there are multiple models. Those models give different scores. So I think the Gale model and I've forgotten the Krauss-Taylor model sometimes give scores of something like 8% apart. That might make a huge difference to when deciding to have a mammography. What are those models doing? Those models are ultimately putting people into different groups and different classes. They are ultimately deciding which classes of people are at which risk. So while the example is incredibly simplistic, I think it does capture something which happens in the clinic. So this is what I'm going to do. I'll just give you a problem. And you might think, well, Steve, this problem is a really simple solution. I'm going to show you why the problem is difficult first. Then I'm going to show you how it relates to a bigger problem, the problem of what I call perlocutionary knowledge. Don't worry, I'll explain as we go along. Then I'm going to give you a solution to my problem, the so-called rational gambler solution. I'm going to show you what the rational gambler solution gets right. So until this point of the talk, all's going quite well. Then I'm going to show you there are two problems for a rational gambler solution. One of the problems I don't have an answer to. The other problem I think really requires us to rethink the answer I first gave you. So in a way my question is very easy to answer. I want to suggest it's far more difficult to answer. So why is the problem difficult? Here is the obvious answer. What should the doctor say to Jane? He should give her the most accurate estimate of her breast cancer risk. Think about it this way. Imagine Jane wants to know what her blood pressure is. Should the doctor, what tools should the doctor use for measuring her blood pressure? Well, obviously, the instrument which gives the most accurate reading of her blood pressure. By analogy, you want to use the class, the model, whatever, which gives the most accurate estimate of risk. Why doesn't that work in the case of Jane's risk of breast cancer? Well, basically, because here we have a version of what Reichenbach calls a reference class problem. Okay? So, on any plausible account of the kind of probability we're discussing in this case, it doesn't look as if there's a fact of Jane. Yeah? Her probability, which is kind of ticking away the same way kind of decaying radium happens. It's unclear what's going to happen to it. Jane either has a tumour or she doesn't. The issue here is, as it were, an issue about, when we calculate probability, an issue about putting a number on that probability. And the number we put on it, according to many people, is going to be relative to how we choose to classify it. Think about my chance of getting cancer. Yeah? You might talk about my chance of getting cancer as a man in the next year, my chance of getting cancer as a Caucasian man, my chance of getting cancer as someone who lives in Cambridge. There are going to be multiple ways of classifying me for figuring out my cancer risk. And on the face of it, each of those claims is true. Yeah? At least as long as the underlying population statistics are correct. Yeah? If you have population statistics on Cambridge, my risk for a Cambridge resident is whatever, 5%. That's a true claim. If you have population statistics on British men, my risk as a British man is 2%. That's correct. Yeah? The problem of the reference class then is finding a non-arbitrary way of deciding which is the correct reference class to use. Okay? There's my risk of cancer, my risk for a man, my risk of Cambridge resident, etc., etc., etc. That's a problem Jane faces. So very quickly, for those of you who know, a very nice piece of paper by Flores and Fuller, they discuss this model of risk prediction, what they call the generalized, particularized model. I'm assuming here the generalization part is unproblematic. I'm assuming that in this case, just to clarify again, we have good population level knowledge, let's assume, of the number of women who will fall into each class. What we don't know is which class to put Jane into. That's a problem. Okay, so that's why the problem is difficult. The problem is difficult because this isn't like measuring Jane's blood pressure, where we could talk of measure it being more or less accurate in a fairly uncontroversial way. Of course, that itself can be controversial, but still. In the case of risk, there is this question, which reference class to assign Jane to? Now, here's what you might say. You might say, Steve, there are solutions to the reference class problem. We just need to pop that solution in. Let's take a step back before doing that. Think about the following question. Imagine I say to you, I've got a 4-year-old child at home. I say, what should I tell my kid about Father Christmas? And you say, Steve, it's simple, it doesn't exist. Is that a good answer to my question? Not necessarily, okay? There are all sorts of issues involved in the communication between me and my child, where, as it were, the facts themselves don't settle what I should say. So note what's going on in the case I just gave you. My question wasn't, what reference class should Jane herself use? My question is, which reference class should the physician or clinician use to communicate to her? So, let's carry on. Let's think, okay, so we're thinking about somebody who's speaking, a clinician who's giving advice, talking to Jane. Here's one answer I often get when I give this problem to people. Different philosophers get this answer. They say, give her all of the estimates, yeah? Tell her her risk is a woman, and her risk is a woman like this, and her risk blah, blah, blah. Because that's kind of really honest. Awesome. Now, I understand the temptation there. Because when you have a hard problem, it's always nice not to solve the problem yourself, but to pass it on to someone else. But I hope it's obvious that that's useless. That's no use to anyone at all. There's no use to anyone at all, because Jane's going to ask a really obvious follow-up question, which is, well, okay, fine, I can see as a woman who has family history, and so on and so on. But which one should I act on, yeah? At 1.5%, I'm not having a mammography. At 8%, I am. Which is the correct one? Give all the estimates isn't the right answer. Here's another answer. Give the estimate which is most likely to have beneficial consequences. Putting the claim this way seems really stark. Let me just suggest that actually an awful lot of medical research works this way. Look at Cochrane guidelines for assessing different ways of communicating cardiovascular risk. The key measure for a successful way of communicating cardiovascular risk is how likely people are to give up smoking. Note what that's doing. That is one of the key measures. That is telling you that the aim of the communication is to have a particular effect. Yeah? It's to get people to give up smoking. I went, this is more anecdotal. I recently went to talk in Cambridge. Well, precisely someone was saying he'd done a very important study, and they were trying to analyse whether in the clinic you should tell people their cardiovascular risk relative to all known risk factors, or all known major risk factors, sorry, or relative to controllable risk factors. What was the way of comparing the two ways of giving the risk estimate? The answer was, again, which one is most likely to get people to exercise? Yeah? Tell people their family history related risk, they think, oh, I don't have a chance. You tell them their risk is someone who sits around all day, they go out for a run. He said, this is fine, because people going out for runs is good for them anyway. Here's a case from the literature on cancer. Really familiar problem. Do you give people their absolute risk or their relative risk? Yeah? Very, very interesting paper by Meslin and Schwartz, where they say, if you're giving people their breast cancer risk, specifically the breast cancer case, they say, give them their relative risk. Why? Because it scares them into having mammography, because typically it's much higher than the absolute risk. This answer, when you put it so starkly, people tend to think, oh, but it's really deeply implicated, I think, in how we think about risk communication in the clinic. And I think it's really dodgy. But here's why it's so hard. Go back to the case of Jane and the doctor. Imagine the doctor thinking, Jane should have mammography, Evan should have mammography, it's great, I'm just going to give her a risk relative to family history. Easy. What he says is true, as long as he phrases it properly. You're a risk given your family history. Your risk, qua woman in this reference class, is whatever I said, 8%. That's true. What's going on here? I think what's going on here is we have a problem with what I call perlocutionary knowledge. Horrible term. If you know a better term, please help me. So in medical communication, like all communication, there are general norms which circumscribe what we can do. Yeah, you shouldn't lie to people. You shouldn't mislead people. Yeah, unless like murder is going to kill someone. Okay? But the norms can be ambiguous and they leave room for communicative choices. By communicative choices, I mean choices about what or how to communicate. So, you know, someone stops me on the street, and they say, how do I get to King's Cross? Yeah? I'm just outside here. If I'm like, just down the road about 100 meters. Okay, that's wrong. Okay? But what do I tell them? You know, do I give them information how to do it by tube, how to do it by bus? Do I tell them how to walk? Do I tell them in English and French? Whatever. Yeah? I have a whole range of communicative choices. What's interesting, particularly in a medical context, is we often have what I call perlocutionary knowledge about different choices. Perlocutionary knowledge, perlocutionary is a fancy term philosophers use to mean the consequences stemming from our speech acts, from what we say. What's interesting is we have huge amounts of medical research on the perlocutionary consequences of different ways of communicating in medical contexts. Yeah? Do you tell people the operation has a 10% success rate? Do you tell them it has a 90% failure rate? We know that has a major effect on the choices people make. Consider absolute and relative risk, the example I've already given you. Consider the genetic risk paradox. I'd love to work on this at some point. This is a funny paradox where if you tell people their risk relative to genetic factors, they tend to engage in more unhealthy behavior, so their risk goes up because they think it's already set. Yeah? We have knowledge about the consequences of different ways in which we communicate. So here's a very general question I'm interested in. When and why, if at all, is it permissible to appeal to perlocutionary knowledge to decide what to say in clinical contexts? Here are two kinds of answers. Answer one, always! Yeah, that's brilliant. That's going to have all sorts, if it has beneficial health consequences, use the knowledge, as long as you don't lie. Yeah, as long as one of the discussants is correct, you can say whatever you want. Here's another answer. You think, oh, it's awful. Never use perlocutionary knowledge. It undermines people's rationality. It's kind of underhand. It's cheating in some way. I take it both extreme answers must be wrong. Always use perlocutionary knowledge. Consider, parents who have prenatal diagnosis, yeah, and they go for genetic counselling. Of course, genetic counsellors have knowledge about the different ways in which they frame, difficulties of, let's say, having a child who's disabled, and they know the ways in which they say that will have an effect on the patients. And generally, we think, as it were, the genetic counsellor should be non-directive. He or she should not use that knowledge. That seems right to me. Never use perlocutionary knowledge? I don't know. I mean, here's the advert you get on the side of packs of cigarettes. What's going on here? I mean, this looks to me like it's a really basic appeal to ignorance, yeah? Does anyone really know why the diseased lung, is diseased? It just looks kind of horrible. Yeah, it's clearly chosen for its effects. It makes people give up smoking, not engages in an irrational argument. I take it that's kind of more or less permissible. We can discuss that. So I think the answer is it's complicated. But here's a general principle for the content of claims. I'm putting to one side the question of how we communicate, to focus now on what we communicate. I think we should avoid what I call wishful speaking. Wishful speaking is a relative of wishful thinking, a more familiar concept. But wishful speaking is when you make claims which don't meet the epistemic standards proper to your social role, because you value the consequences of other people believing those claims, regardless of the epistemic status of the claims. That's a bit tricky. It's on your handout, so you can go back to it. This is why we have a handout. People can go back to it. Okay, let me just give you an example. Consider my favorite medical controversy of the last 15 years over the MMR vaccine. Okay? What's fascinating about this controversy is everyone involved in it accuses everyone else of what I call wishful speaking. Okay? What happens when Andrew Wakefield claims the triple vaccine for MMR is unsafe? People say, that claim didn't really meet proper standards for making medical claims. The reason Wakefield said it is because he was involved in this kind of legal case being brought by parents, and it was in his interests that people believed the MMR vaccine was safe because it would help the legal case. who's engaged in wishful speaking. Interestingly, on the other side, what does Melanie Phillips in the Daily Mail tell us? Perhaps plausibly in this case. Okay? Why do the public health professionals, why do the epidemiologists tell you the MMR vaccine is safe? They don't really have the right evidence to say it's safe. They're telling you that because they've done a giant cost-benefit analysis, which tells them even if it is unsafe, better off for people to vaccinate their kids. I don't know if either of those accusations of wishful speaking are true. What I think they're important for is illustrating we think wishful speaking is bad. Okay? If you can locate someone who's engaging in wishful speaking, that's a bad thing to do. You violate a kind of communicative obligation. Okay. So, let me now go back to the case of risk very slowly. So, in the case of risk, what am I saying? There is this very familiar literature, a huge literature, on how we present risk claims, okay? And the effects of those different modes of presentation, yeah? I have colleagues in Cambridge who do really interesting work on this. Do you give risks as natural frequencies in terms of pie charts? Do you give them using fractions? Do you give them as betting odds? And so on. Lots of literature on the how of risk communication. But here's what I think lots of literature misses. The reference class issue, the case of Jen brings out. There's a what question for risk communication as well. What risk do we communicate? Yeah? What reference class do we put people into? Do we give people their risk qua woman with his family history, qua woman who breastfed? It's not just the how, the what. Yeah? And exactly what's going on in lots of these things. The Cochrane review I gave you, the CVD case I was discussing, Meslin and Schwartz. I mean, relative absolute risk is interesting. It's somewhere between the how and the what, actually, risk communication. Come back to it. In those cases, people are saying you can appeal to perlocutionary consequences to decide what risk estimates give. Now, I think that's problematic because if you do that, there's a risk you engage in wishful speaking. You are making a claim which, in your social role as a clinician, you shouldn't be making. Maybe. Back to the background. Let's try to spell that out. So, just, I'm told this is, do you want to do PowerPoint? Here's my outline. Okay? So we're moving on now to see how that problem I said was harder than it first seemed. This stuff on perlocutionary knowledge, how they combine to give us a way forward here. Okay. What is the social role of a doctor? Remember I told you, I take it the concern about appeals to perlocutionary knowledge, the concern about, just getting people to give up smoking or whatever in those risk communication cases, is in some sense it goes against the social role. What standards should govern your social role? What is the social role of a doctor? Well, here's one answer. The social role of a doctor is just to make people healthy. If that's your account, I don't think you have any good account of why appeal to perlocutionary consequences might be so bad. So I take it, here's a different way of understanding the role of a doctor. It's to help the patient to make an informed decision. And what follows, I'm just going to assume answer to. Okay? In a way, this is just assuming a huge amount of debate in medical evidence. I assume when a doctor is speaking to you as a patient in a clinic, her job, her social role, is to help you, the patient, to make an informed decision. Her role is not to treat you as kind of mere means to the end of making you healthy. Claim 1. Claim 2. Rational gamblers. Which reference classes should we use? Well, I mean, is anyone who's ever read up on this, guys? There's a very standard answer, okay? And this standard answer, when you go to philosophical issues here, seems to hold, even if you think with the kind of roughly frequentist interpretation of probability having a working group doesn't quite work and so on. I mean, roughly, the idea which comes from Reichenbach, who first formulated the problem, is used the narrowest available class for which reliable statistics can be computed. Okay? That's the answer to a reference class problem. So you've got a future event which falls into several different classes on which you've collected statistics. Check for all those classes if your statistics are reliable, then use the narrowest class. Okay? That's where the smallest class. Why? If risks aren't out there in the world, what grounds this claim? Well, here's a standard answer, taken from people like Simon Blackburn, particularly in this case. It's linked to a theory of rational decision in gambling. Lots of ways of spelling this idea out. Just to get an intuitive grasp of it, here's an example. So imagine in all of Andy Murray's matches so far, Murray's won 60%. Okay? So that's Andy Murray looking happy. For once. In his matches against Djokovic, he's only won 40%. No wonder he looks so miserable. Okay? Imagine now that those patterns will continue. Okay? The overall average for Murray is 60%. The average against Djokovic is 40%. You are betting on tennis a lot. You bet on all of Murray's matches, assuming a 60% chance he will win. Okay? The bookie, by contrast, assumes that Murray's chances against Nadal are 40%, his chances against everyone else, let's say 69%, given whatever the background numbers are here. What's going to happen here? The bookie can now make you a series of bets where you are bound to lose money in the longish term. Okay? You're bound to lose money because the bookie will say, look, so against Nadal, I'm offering these odds, you pick brilliant. His chance of winning is 60%. Take that bet. Against other people, she'll offer you odds, and you say, it's crazy. Murray's chances of winning are only 60%. I'm not going to take that bet. What happens if you bet in this way, which doesn't make use of an arrest available reference classes? This is what happens, okay? You end up in that situation. That's the underlying intuitive thought here. There are lots and lots and lots and lots of ways of spelling this out. I don't want to get into details here. I just take it the intuitive thought is more or less correct. So what happens if we just combine the two things I just told you? We say, look, given the clinician's social role is to help patients make informed choices, and given the choices involving risks are best understood as a kind of gamble, then the physicians should state the patient's risk relative to a narrowest reference class for which reliable statistics can be compiled. Okay, so to apply back to our case, answer B, giving the risk qua age and family history is preferable to a risk qua age. It's a narrower, I'm assuming statistically reliable reference class. Similarly, the risk qua breastfeeding is preferable to a risk qua age. What happens if you want to, if we can combine the estimates, if we can figure out the risk qua breastfeeding woman with this family history, even better, even narrower reference class, great. What happens if we can't combine the estimates? Then it's tricky. Then it's really tricky. And then a lot turns on how you interpret narrowest available reference class to be sorted out, hopefully by the clever people who look at these kinds of topics. So what have I said so far? Well, you might think, this is blindingly obvious, and why have I sat here listening to someone tell me something so blindingly obvious? Of course she should be using age and family history, knowledge, of course. But note two things. Remember the Santa Claus example. It's not trivial that just because the gambler would use those reference classes, the person informing the gambler should. Note also that what I'm going to go on to show is that because we had to get here via gambling, via the theory of rational decision, we can't get here just by talking in terms of measuring a property out there, the way we might in the blood pressure case. There's an instability in the answer. That's what I'm going to kind of go on to in the rest of the talk. So let me kind of help you understand why it's not necessarily trivial. I think this model helps us understand something quite interesting. It helps us understand how risk claims could be true, but misleading. Yeah? If a woman comes to a doctor and says, "Doctor, what's my risk?" and he knows her family history, he knows that she breastfed, but he says, "Well, your risk as a woman in your 50s, 3.5%. I take it, something feels wrong there. The statistics are correct, but it's a lie. Maybe even a damn lie. Why? I take it because even if what he's saying is true, it's misleading. In his social role, the woman assumes that what he is doing is giving her the narrowest available reference class, and he is flouting that conversational norm. He's playing on it. Yeah? It's the same kind of case where the ill old lady in the hospital says, "How is my son?" And you know he died that morning, and you say something like, "I saw him yesterday, he was fine." What you say is true. It's not a lie. But it's also misleading because there's a basic kind of conversational norm that you give as much information as possible in those contexts. I take it the doctor is flagging that norm. In a funny way, the doctor is more like a spin doctor. So this is Alistair Campbell, Tony Blair spin doctor. The most interesting thing about spin doctors is the first rule of spin doctoring is never lie. Yeah? Never lie. This is what Dr. Campbell says in his autobiography. The trick is to say true things, which somehow mislead. I think the doctor who appeals to perlocutionary knowledge is being a spin doctor, as it were. Second interesting feature of this result. Note the importance of the social role of a speaker and her relationship to the audience. So, this is kind of running sub-theme here. Reporting absolute versus relative risks. If I read one more paper by a philosopher where they say reporting relative risks is deeply misleading, I'm going to go crazy. I'm going to go crazy because I think we're missing an important ambiguity here. If the doctor is speaking in the social role of a clinician speaking to a patient, then I take it the relative risk information might well be misleading, because that's not the information the kind of gambler will want. If, however, she's speaking as a researcher to a policymaker, I think it's very different. I think it's very different because relative risk scores are incredibly important for public health policy. Yeah? The problem you have in reporting relative risk scores to patients is a problem which arises in EBM by assuming that epidemiological data isn't just suitable for epidemiological purposes in public health, but suitable in the clinic. So I think it's focusing on this issue of social roles helps us get somewhere in understanding the how. Let me just push on that for a little bit, because there's something else going on. I told you that if the woman goes to a doctor, and the doctor tells her, her risk qua age, when he has information about her risk qua woman who breastfed, qua family history, whatever, that's problematic, that's misleading. Note how my example started. The woman gets a letter from the NHS telling her, you're in that 50 to 70 age range, about 3% risk of breast cancer, come along for screening. Is the NHS systematically misleading people in its screening programs? That seems a very odd result. What's going on here? But here's what I think of this account, where it gets rough, what it helps to understand. I think some of our decisions about which risk claims to make are driven by perlocutionary concerns in an acceptable way. I think this is a screening case, let me explain. But I think the relevant concerns, the concerns about consequences, may lead us to report claims which are based on very broad reference classes. And this arises because of Rose's fundamental axiom of preventiveness. Okay? So what does Rose tell us? And, I think it's like the most important, interesting book in public health ever written. Fundamental axiom. A large number of people exposed to a small risk may generate many more cases when a small number exposed to a high risk. Why is that important? That's important because let's say this is a graph showing risk of CVD related to a cholesterol level. Here you have the old cutoff point for screening in the US, just to the right where it's red. Then you have the new cutoff, proposed cutoff screening where it's yellow and red. What's going on here? Why would you screen people who, why would you move down the cholesterol level? The point is because those people are, each one of them is at a lower risk of cholesterol, of CVD, cholesterol-related CVD, than the people in the high-risk group. But if you want to save as many lives as possible, just intervening on the far right is going to be a bad way of doing so. Because many more cases are emerging in the moderate risk group than in the high risk group. Go back to breast cancer screening. Okay? We screen in the UK, every woman, between 50 and 70, moving 47. Okay. Here's what we don't do. What we could do instead. So doing that means you're intervening on a very, very, very kind of broadly defined reference. Okay? You could do something else. We could have genetic testing for every woman, see who's got BRCA1, BRCA2, invite in just the BRCA1, BRCA2 women. What would happen if we did that? Well, of the women we screen, we would pick up many more cases. But overall, we would pick up far fewer cases than if we used the very broad, very heterogeneous, very messy, age-based reference class. I take it that those kinds of policies are perfectly legitimate. Yeah? Given the goals of the public health system is to reduce overall mortality and morbidity, then we need to just intervene using these very broad reference classes. That's a kind of cost-benefit analysis. It's appeal to consequences, okay? There are huge, tricky issues around how to do a cost-benefit analysis. But, however we resolve those issues, there's something interesting going on here. There's this worry that once we've resolved a problem and used these very broad reference classes, what we end up saying is something like, it's worth screening this kind of woman. What we mean is, given the huge cost-benefit analysis, screening women in this very broadly defined reference class makes sense. That doesn't seem to apply for any individual woman who's identified that way. It makes sense for her to be screened, for at least two reasons. She might as well have different values. Yeah? When you do a population level kind of estimate, you just assume things like, how bad is it to have misdiagnosis? How bad is it to have unnecessary worry? How bad is it to have breast cancer? Plausibly, an individual woman might have different values. She might think, I'm really worried about misdiagnosis in a way which isn't captured at the population level. But more interestingly, from my kind of perspective, she might have different risks. Yeah? Even if it's a case that it's true that for women between 50 and 70, their risk is pretty, a little bit over 3%. For an individual woman who's breast cancer, an individual woman who knows her family history, it doesn't seem that that's an accurate representation of her risk in some sense, essentially spelling out. So I take it that what's going on is that the rational gambler model, what it gets right, is it helps us think about how to respect that gap between a population perspective, where it is fine to appeal to perlocutionary considerations. A screening program is, in effect, a decision to tell a large group of women what their risk is, as a way of getting them to act a particular way, where all of that is based on knowledge of consequences of doing that. That has to be fine, I take it. But what the rational gambler model helps us understand is that the role of the doctor is, as it were, to bring in the individual decision-maker's perspective inside that overall policy. And that's why we appeal to perlocutionary considerations of the clinic. It might seem problematic. Okay, so that's what the rational gambler solution gets right. What are the problems? Well, roughly, I think there are two problems. Problem one is what we are. I don't know what to say about this problem. Once I went to a session on how to do a presentation, and the advice was something like, when you're giving a talk, always have a bit where you pretend you don't know what to say. So then people will ask you questions about it, but really you know, so you can give them present answers. This is genuine, I really don't have a clue. Okay, so talking about communication. Okay, here's a datum. Most people don't make decisions in the ways in which a rational gambler would. Here's Dr. Strangelove in a famous film, yeah? He's the arch rational decision maker. Most of us don't reason that way. In a way, that's exactly what our knowledge, our perlocutionary knowledge tells us. People fall prey to framing effects. Yeah, but rational gambler understands 10% survival, 9% failure, 9% failure, it's all the same. People don't. The rational gambler knows to look for absolute risk, not relative risk. Everyday people don't. The rational gambler doesn't necessarily think in terms of minimizing regret. That's exactly, apparently, a major driving force people actually turning up to regular morphine. We don't act like Dr. Strangelove. Why does that create a problem? Well, I think it creates a really weird problem. And the problem is that the rational gambler model might appear to be either disrespectful or disrespectful. Let me explain why. Let's assume that rational gambling is, as it were, a binding item. Yeah? We should be rational gamblers even if we fail. Well, if we should be rational gamblers even if we fail, you might think that actually appealing to perlocutionary considerations isn't so bad after all. It's a way of getting us to be what we should be. It's a way of, even if it's trickiness, it's appealing to our true self. That's exactly what Mesler and Schwartz say in the paper I told you earlier about absolute and relative risk. They don't say you should give women a higher relative risk rather than a lower absolute risk because that makes them have a mammography strictly. They say a rational woman would choose to have a mammography. Individual women are just irrational often. By giving a relative risk, we're helping people be irrational. You can move that over to my kind of case quite easily. That's one way. The rational gambler model is the right model of rationality, but then we're being disrespectful to people. Of course, here's the other way. The rational gambler model isn't the right model, in which case, treating people as if they're rational gamblers is disrespectful. As it were. It's disrespectful because, if people really deep down aren't rational gamblers, and we treat them as if they're rational gamblers, well, why do that? Yeah? Why treat people in some way they aren't? They shouldn't be. Why is that to respect over time? Like I said, I don't really have any useful answers here. On the second issue, the only thing I can possibly say is that given the history of how we think about risk, given that our concepts of probability and concepts of risk are so tied up in theories of gambling and rational choice, I don't really see any way to resolve the kinds of problems I've given you if we kind of start to assume people deep down shouldn't be rational gamblers. There's something deeply flawed with this entire model. There's something very deep going on there. The entire edifice starts to collapse. On the first issue, on a kind of sense of disrespectful sense A, all I can bring to say here, like I said, I'm genuinely a bit stuck on this, is there's some kind of epistemic problem. Yeah? If our preferences are so malleable that I'm not entirely certain, who knows what's in our preferences. That's not really a very good solution. So that's one problem for the rational gambling model. I think we can kind of fight it off with time. Here's the second problem. Oh, sorry. I meant to read that slide, sorry. Here's the second problem. What we do. So what I'm going to suggest is what actually happens inside, let's say, UK healthcare and so on, looks an awful lot like a rational gambling model, up to the very last moment. And then we have this interesting problem. Is what we do wrong, or is my model wrong? So what we do. So again, go back to level 55 for influence. What involved in risk prediction? We generalize from a study to a target population, we generalize the population level frequencies, and then we particularize. We move from frequency population level data to an individual probability. Yeah? We move from, in this study, we found breastfeeding women, whatever, this kind of proportion. We see the same frequencies we expect to hold in a target population, and then we take an individual woman. Here's your risk, we particularize. In particularization, as Florence pointed out, there might be three issues. First, where the individuals are really members of relevant categories. The problem is if you can actually assign people to those categories. Then they say that furthermore, we should double check the degree of homogeneity of the category and the narrowness of the category. I take this to be a way of saying we should use the narrowest available reference classes, as statistically available reference classes. Seems plausible. And what happens then in real life cases? Well, of course, in real life cases, cancer prediction, we use models. We might use a Gale model, which is going to use these different factors, and in effect, you already know this, but I do, you'll plug in these numbers to get some kind of prediction of individual women's risk. What's going on there? It's a form of particularization using population level data. The model is going to be validated on the initial study population, then the subpopulation predictions will be calibrated in the treatment population. We double check that roughly using these models generated in the study is capturing what we care about in our actual population. No, so far that looks all really, okay, more or less in line with what I said. But here's the problem. We have well-calibrated models. And we might still be worried about them. We could have a model which allows you to make predictions across, which allows you to kind of group women into different risk categories. And it's well-calibrated in some sense, in the sense that the actual observed frequencies more or less match the frequencies you predict. But those models could perform badly relative to other plausible risk factors. Yeah? So the Gale model is in a sense quite well calibrated. But we have the Klaus model. Klaus model also takes account of more genetic factors, as I understand it. And then if you kind of run the same, you take the same women, then you double check what would have happened if you'd used the Klaus model. You see that there are various women who are put at lower risk by the Gale model, at higher risk by the Klaus model. Then you take the actual frequencies among those of cancer among those women, and the Klaus model is, as it were, closer. Second way, you can have a well-calibrated model, but still a very broad model, yeah? In a way, doing it by age. If you just used age in the clip, you'd have a really well-calibrated model. But obviously it would be very broad. So what I take this to be a worry about is a worry that might be statistically reliable, narrow classes available. I take it that this is what's going on when people raise this kind of concern. But of course, what we can't do to compare the models is ask which model is close enough to the true answer. There is no true answer out there, as it were. There's just the answer given different models. So the question is, which models generate narrower, reliable classes? How do we do that? We do that using reclassification analysis. Reclassification analysis, whenever I've tried to read up on it, seems to be a bit of a black hole. But the basic picture, as I take it, is that we have some way of categorizing people, let's say using X model, and let's say using X and Y model. We use the two models, and then we see where women are placed in different risk categories, let's say breast cancer. The diagonal are women who are placed in the same categories by each model. Yeah? The off-diagonals give you the women who are placed in different categories. So the X plus Y model might put 50 women at high risk, who, using just the X model, would be put at low risk. What do we then do? Roughly, it's a very complicated mathematical check, but we see what happened to women in those groups, the actual population frequencies in those groups. Yeah? So if among this group of 50 women, a decent number of them actually got cancer, the kind of number we associate with high risk, then the X plus Y model is preferable. Broadly, also need to double check. So that's reclassification analysis. It's a bit of a black hole mathematically, as well I understand, but it gives you a way of comparing models. And what looks to be happening here is that if you have a model which, as it were, brings in more reference classes, which is exactly what's typically happening, brings in more variables, what we're doing is we're checking that model is better calibrated. If a model is better calibrated, then here's what you might think. Easy. You have found, as it were, a statistically reliable, narrower reference class into which to put them. Or the model will give you statistically reliable, narrow reference classes. Yeah? Is that sufficient to justify use of model in practice? Of course not. Always a fair question in any medical literature on this. What's the cost of a reclassification? Is it worth, okay, what is the improvement worth the cost? This is the final question you see in nearly every paper which does a reclassification analysis. Actually, if we'd done this model, if we'd used this model in the clinic, how many more lives would it have saved? Given plausible assumptions about how people respond to being given this information, given various treatment guidelines, given standard procedures, so on. Is that benefit worth the cost of introducing a new model into general practice, given the cost of introducing a new model is often quite expensive? Here's what I find interesting here. Is that final step justifiable? So far, it all looks like this is just a way of, what I've said is a way of kind of giving you some underpinning of what actually happens until that final stage. So I say, look, if that's what we're doing, we're failing in our communicative obligations. Because the entire point here was what the role of a doctor is to do, is to give women the most accurate estimate. The most accurate estimate is the estimate relative to an narrowest available statistically reliable reference class. The doctor is not meant to have all those perlocutionary things going on. It is her role, as it were, to stop that bigger system impinging on the individual woman's choice. And note what's interesting here. Of course, there are all sorts of cases where you might be involved in something which looks a bit like measurement, and where you might decide to use a less reliable model rather than a more reliable model. But typically, we might say that that's because it's reliable enough. Yeah? It's like doing the blood pressure reading. It's a bit less reliable, a bit less accurate, but it's close enough. We don't have the independent standard here of good enough. Because the standard is always relative to the model we use. So what we do looks problematic. Well, I think it is problematic. But I think it's problematic because there's a funny analogy here to what happens when people come into a clinic and they ask the GP, GP diagnoses them, and then the GP might make them a series of kind of options they can take. Where these options they can take will will be constrained by the background issues of resource allocation. Yeah? When you go into a clinic, you know, if NICE has said this experimental treatment which costs £100,000 per quarter or whatever, that's not available, you don't get offered it. Your rational self wants it, let's assume. Your rational self might want that to be on the table, but I take it that the fact you can't have it is kind of justifiable because it's reasonable. Yeah? It's reasonable that you, living in a political community, would sign up to a system which rations your healthcare in that way. And I take it that what's going on in this case is something similar. Even if a purely rational agent would want the narrowest available reference classes, they want the model which does best after reclassification analysis and so on. Appeal to these considerations can justify not using various models because it would be unreasonable to do so. Unreasonable, in that case, at least as long as mass is working well in the treatment case. At least as long as reclassification analysis, economic analysis is working well. So what I'm suggesting is, given their so good social role, good clinical risk communication involves treating patients not only as rational gamblers, but as reasonable citizens. And that will sometimes mean not using the narrowest available reference class. And I take it that that does not appeal to consequences, but a different kind of consequence. Yeah? It's not the consequence for the individual. It's something like background social consequences of having a system in place. Note also why there's something more complicated going on here. Because we know for risk classification, there are all sorts of procedure categories. Yeah? There's literature on the possible relationship between sexuality and breast cancer risk. We want doctors to be using this information, we want to put it in models. It's unclear. Most people feel very uncomfortable about it. Think about debates like ethnicity used sometimes in these contexts. People are very funny about using ethnic classification. In some sense, refusing to use ethnic classifications is to fail to give people the narrowest available reference class. But I take it if concerns about racism are good concerns, different question, then it might be justifiable. Consider France. In France, apparently for cardiovascular screening, they don't use ethnicity because they think it goes against the values of the secular state. I don't think that's completely crazy. But I think you need something like this model to understand. So let me just summarize very quickly. Okay? Which reference class do you use? That was our problem. The underlying issue were ways like appeals to perlocutionary knowledge. The initial solution, I gave, was the social relevant initial as enabling rational gambling. The first problem, and the key problem, was that's not what we do. So what I suggested instead is what we do is justifiable because we should treat patients not only as rational gamblers, but as reasonable citizens. So is it possible to communicate cancer risk accurately? It's possible, but it's not necessarily what we should always do. That's what we're taking the answer. This is very kind of convoluted. Let me just very quickly leave you away, perhaps prompt a small discussion. What are the implications? Think about the use of nudges. Everyone loves a nudge. Maybe I'm way to go. I take it to what's going on here, communicative nudges. The communicative nudges are very different from other kinds of nudges. So there's an issue over clinical ethics. Think about public health ethics. What should you say about this screening cases? Yeah? There's just a question I put to one side there. When are decisions by risk models justifiable? Think about the mental philosophy of medicine. What should we research? If we know that certain categories are, as it were, forbidden categories in our community, categories which would never actually enter into practice, does that affect what counts as useful knowledge? Policy, beware personalised medicine. I take it that the purpose of personalised medicine, I have an idea of what you do is you can sort of get down to the individual. But the individual will always be viewed relative to a reference class. I think that probably never goes away. That's all I have to say. Thank you.
Thank you, Steve. Now I'm going to comment from Dr. Deborah Ruddy, a consultant clinical geneticist at guys at St. Thomas Hospital.
Hi everyone, I'm as you just heard, one of the geneticists here. I will say, Steve, thank you for a great talk. There's very little philosophy in my clinic room, so you've given me lots of things to think about. Steve very kindly sent me his slides yesterday, so I could just have a look at what he was going to say. I've never heard the word perlocutionary before. I'm sure I'm not the only one, so it was interesting to find out what that meant. Now, the talk today was really about risk and communication of risk, and of course the philosophy of risk. The one thing that I want to say from my clinical practice is that every single person that we see, certainly in the genetics clinic here, understands risk in a very different way. Some people think that a risk of 10% is an extremely high risk. Some people think that a risk of 10% is a very low risk. And yes, it's very important that ultimately we can put people into the correct screening categories and we have the right decision-making tools for putting them into the right categories. But we must never forget that each patient that we see has got their own views on what's important to them. And one of our skills, or our jobs as a doctor, I think, is to work out what that person's perception of risk is. The other thing I want to say is that people's perception of risk, particularly of breast cancer, has changed enormously in the 10 years that I've been a consultant. 10 years ago, we didn't have the social media that we have now. We didn't have the knowledge that we have now about genes that cause breast cancer. And now we have people like Angelina Jolie advertising, I think in a very good way, what her genetic status is, which has increased people's perceptions of risk in an extraordinary way. The number of referrals that we've had coming through our doors has massively increased because people are now worried about their risk. The risk or their feeling of risk, I think, has been normalised. They think, well, if Angelina Jolie has got a risk, maybe I've got a risk, maybe I can talk to other people about it, and that's why they're coming. So my points really are, everyone's perception of risk is very different. People's perception of risk is changing. Now, when we come to screening, I don't really know what to say about the philosophy of screening. I'm a great believer in screening. I believe in screening systems and protocols that have been set up by the NHS with, I believe, good evidence. Whether or not that screening is always accurate, no, of course it's not. Whether it detects every single case of cancer, no, of course it doesn't. But I believe it's a very good model for identifying those most at risk. The final thing I want to say is that Steve briefly touched upon the BRCA1 and the BRCA2 genes, which I've alluded to already with Angelina Jolie, and personalised medicine, and why don't we just do screening of everyone to see exactly what risk people are all at. Now, in an ideal world, that would be a great way to carry on, but the situation is that we don't know of all the genes that cause breast cancer. There's only some cases of breast cancer that are caused by gene mistakes, so we're never going to be able to be in a situation where we can look at everyone who's at risk of getting breast cancer, i.e. certainly every woman, and do a gene test on them to see if they're likely to get cancer or not. Even in those that we do test and we do identify gene mistakes in the genes that we know can cause breast cancer, those women still don't have a 100% chance of getting breast cancer. So I think that's all I've got to comment, unless there's anything else you want to ask me about, Steve, while you make copious notes. Anyone else?
Should we maybe turn the lights up a little bit? Is this on?
I'm dealing with my role.
Yeah, that's what we call it.
My name is Omar. Thanks, that was really good. I just wanted to ask, I fear I may be being slightly ignorant here or short-sighted, but I wanted to respond to that point about sensitive reference groups. So, for example, ethnicity or sexuality. And I was thinking to myself, when I examine a patient or take a history from a patient, I ask in basic things, and patients understand why I have to do that, because I'm trying to get the best information. Why do you, in your opinion, is it different in this case?
It's a good question. So, I'm not sure that it is. Okay, so maybe it is. I don't know. Maybe it's going to tell me something. So what I wanted to say was not so much, I think it's definitely different, but I can understand how there might be concerns, yeah? Particularly when you're thinking about something like screening and routine use of information. So there might be particular people who don't want to use the information or develop the information. And I think what's interesting about thinking about screening is one of those kinds of contexts is precisely because you want to normalize everything and have same protocols for everyone. There's an interesting sense in which you might want to push away from using disputed or contentious classes. And I think that's a kind of just, I think it's an open question as to whether the kind of political or social kind of benefits of maybe not using particular classes outweighs the kind of external costs of increased accuracy. So I simply didn't want to say we definitely shouldn't, or even part of that. But I think it's more that what I wanted to try to do was to think through a model which would help to understand that tension. Yeah, because I have spoken to colleagues from France and from the Netherlands as well, where they don't use ethnicity for various kind of purposes. So including things like cardiovascular risk, where there's a strong link in people from South Asian kind of backgrounds. Cardiovascular risk, and we just don't use it as a matter of state policy. And part of me finds that very puzzling. Part of me kind of understands roughly where it's coming from. So I guess what I just wanted to do is have a framework for even beginning to have debate. Where the debate goes.
Do you think it's possible that the tension could be resolved to a certain extent by asking, so for example, where this one arises, I can ask my patient, theoretically, what do you prefer? What's the problem actually is a small cycle. If you have the information, I feel.
I mean, I guess almost everything there depends on exactly how the models work. Yeah. I mean, how much information you can kind of plug into a model, or you can kind of feed out. And now I just don't know.
Thanks very much.
Oh yes, sorry. Cool.
Yes. You talked about refinement of models, I would say on CBD. When you think about the issue that you've heard of, this, what you see is all there is. There's a sort of heuristic where if you don't hear it, you don't see it, you don't respond to it, so you just assess sort of boundary rationality, you're only taking the information that's in the vicinity of what you've learned. That's got as much impact as what class you might put it into. So the world is never perfect, so in a very tightly bound level and amount of information, you have to make a decision based on imperfect information. So often you're sort of satisficing and just trying to make the best of what you've got.
So do you mean from the perspective of the individual patient, or from the perspective
of the individual patient? So you're talking about very, very fine nuances of models.
Yeah.
But most of the time, I don't know whether we're actually aware that we're only getting maybe half or three-quarters of the information that we actually even need for a model.
Okay. So exactly. So I guess what I find interesting here, no, it's a nice question, is, so I guess when I first started thinking about these questions, I assumed, the difference between the models doesn't really matter. So I guess basically I started thinking about this. I was just thinking about screening in general. And then I was thinking about what happens in the clinic, I should look into it. And then I started reading on the literature, and just the realization that the different models can differ really quite substantially, at least to some people, some of the time, in ways where it seems completely reasonable to think that that might make an impact on your choice. So, if you have something like, I've forgotten the exact statistic here, some models just by introducing one tiny extra to the family history, some women, you get an 8% increase in absolute risk of breast cancer. And I guess the issue is, for an individual woman, what's the right model to use? What's enough information? In that case, it could really be the difference between having the model free, not having the model free, between taking steps to reduce risk, not taking steps to reduce risk. So while I understand why you might want to think satisfies and there's limited information you're planning to use. I think the worry here is that it feels quite deep, the difference. You know, the kind of sense of, well, I've used enough information, it was accurate enough. And in some sense be misleading. Or it's the sense which is misleading is exactly what's driven me up. No, thank you. Yeah, no, I think I really answered your question. See where you're coming from.
Hi, yeah, thanks very much. I didn't quite get the last move. I mean, I was with you when you got this cozy combination of the rational gambler model and the narrowest class for which there are reliable statistics. And I can see that doing the work required to get reliable statistics for an even narrow class may be costly and not implemented. But that's I didn't understand the connections with that, because obviously we need reason wrong statistics for these narrow classes and can't use them. And then the business about perlocutionary knowledge.
Sure.
So what's wrong with, we've got the narrowest classes in which we've got reliable statistics, and we give people risks relative to those, and that will enable rational gambler to come up with the most informed decision, and we therefore fulfill social role of doctors. What was wrong with that?
No. Thank you. You're completely right to ask, because exactly, stuff towards the end is. So to be honest, I thought I had a solution, and then I realised I had a problem. And then when I still tried to figure out my problem, I had a solution. So I take it that the concern I had went something along the following lines. And that I was kind of starting from the image of the doctor in the clinic, yeah? And just imagine the doctor could, as it were, say, I can use model 1 or model 2. And the doctor knows that model 2 does better on reclassification analysis. But it knows that if the doctor has that information, then she should use model 2 when speaking to a patient. Then my concern was, of course, the doctor doesn't really control which model she uses, complex social system behind the doctor, as it were. And then we look at what happens in those social decisions. Well, of course, the social decisions, issues of cost come in. So then the worry is, well, what does that mean about the status of the doctor? There is, as it were, this information out there, which the doctor could be using, the doctor in some sense should be using, but we're stopping them from using it. And then I thought, okay, so the obvious analogy is the way in which Marx, in some sense, places limits on what doctors can prescribe. Yeah, in some sense, I suppose. And then the worry is, well, isn't that to kind of undermine what goes on in the first part of the talk? Well, I said, no, you should look at the consequences, you should look to the individual, not the population. And what I want to say is, no, yeah, exactly, it's a different sense of looking at the population. Yeah. Maximising under resource constraints isn't the same as picking a model just to get people to do what you want them to do. But that's a really kind of fine distinction. If it's useful, I know I'm sort of busy. There's a really funny analogy here to a case which philosopher called Francis Cant discusses in 3 different contexts. So Cant is interested in relations of intention, and what you intend, with what you foresee. But you have this really funny case where you invite people to a dinner party, but you hate doing washing up. So you only invite people who you know will do the washing up after your dinner party. And I'm fascinated, well, did you invite people to your house to do the washing up? And the answer is no. You know, despite the fact that you wouldn't have invited these people but for the fact that they do washing up after a dinner party, you don't invite them with the intention of having these people come to wash up. So there's some funny sense in which a predicted consequence is a condition for what you do, without being something you intend. I take it, it's a very long window again, I take it there's something finally related going on, actually, like screening, giving risk estimates and so on. This isn't really answering your question, but it's one way of understanding how it's two specters relate. Because, of course, it would be really strange if the NHS sent out letters to each and every woman in the UK. So, between 50 and 70, you should come to breast cancer screening. No, but none of those women would come. Yeah? Whereas it's a complete utter waste of money and time and effort. But does that mean that when you send out the letter, when you give advice and so on, you should always be aiming to get women to have them on food? No, it doesn't. There's some weird sense in which the practice is dependent on certain consequences coming out as a result and certain kinds of considerations, without those necessarily feeding into your intentions, what you're doing, your action form. That's a kind of distinction I'm after. But yeah, it's a really tricky distinction. So here's a different case, which I think is really, really interesting, which is like this. So it's Down syndrome screening and prenatal diagnosis. So I don't need to stay away from those issues, it's so complicated. But yeah, we say when we do prenatal diagnosis, we do so with an intention that each woman, set of parents, should be able to make an informed choice about whether they want to abort. We also know that something like 90% of women who get a Down diagnosis decide to abort. I think it's also very plausible that if it weren't the case with so many women chose to abort, we wouldn't have a program in place in the first place. But that doesn't mean that each time a woman goes for counselling after a genetic test, the aim of the counselling should be to get her to abort. Again, it's about kind of distinction between the set of consequences which justify having the practice in place and the individual in front of you. That's what I'm trying to figure out. But yeah, thank you.
Hi, thank you. Thanks for your talk, Steve. Well, I understand the part which you said that maximizing accuracy is only one part of the story. Yeah. There are also the issue of utilities. And there are two kinds of tensions. The tension between the risk of the individual and the risk of the population, and the tension between utilities of the individual and those assigned to the population. Currently, the screening policies are based on various assumptions about risks, about the generalizability of that risk and the utilities. My question has to do with, insofar the only thing you know about the patient is, for example, a broad preference class. For me, it seems reasonable to send a letter to request someone to go to screening. But what happens if you see the patient, you got more information? Would you approve or would you agree to the idea that the doctor abandon the policy and apply the strategy of the reasonable gamble because he has more information about the patient and because he has access to different utilities? So you have two kinds of situations: a situation in which you don't know more about the patient and you act on the basis of that, and then a situation, different one, in which you got the patient and you will follow a different course of action because of the information you have. I don't know if at the end, my question has to do with the space for judgment of the individual clinician. What do you think about that? If the NHS should increase the room for judgment in the aspect of risk, because for the moment the NHS leaves some space for the issue of utilities and preferences, but not for individual risks.
Thanks. Yeah, I don't know. I mean, this is why, okay, so it's a nice question, because one thing I find very puzzling about risk cases is exactly this. I teach medical ethics, and in medical ethics we always have this kind of model where, the doctor, as it were, sets out the options for a patient, and then there's a patient's values, and the patient decides how she values different options, and then in some sense she decides. you know, I mean, there's all sorts of problems and worries about that model, but roughly it seems to me to capture something important, you know? Just because a doctor thinks you're crazy to disvalue this outcome so much or to value this outcome so much, it doesn't matter. It's a patient's choice. But exactly what I find interesting is when it comes to the risk communication, that's the part where we seem to think, well, exactly, the doctor just passes on a piece of information. And there might be a tricky question about how she passes it on. So that's the issue, framing effects. Where's literature on this? But yeah, I think what's really interesting is, okay, so that's a nice way to put my question. What should the doctor pass on? How much discretion should she have? And in a way, exactly, I take it that the logical extension of taking the patient's value seriously is as where you take the patient's particularities in terms of risk seriously. Because in taking her value seriously, you are allowing her, as it were, to make a gamble. But if you're going to allow her to make a good gamble, you should give her as much information as possible in this way. So roughly, yes. I mean, that's where the position pushes. But of course, there are all sorts of reasons to want. Okay. There's all sorts of issues. One is just about cognitive overload. You know? One is just, there's a lot of time. One is just people might be very bad at making, individual physicians might be very bad at making those judgments on the hoof. And there might be good reasons to think overall it's more accurate to align the model, and so on. But yeah, I take the underlying normative idea pushes you towards more and more particularization in the risk information, subject then to all those background considerations, which automatically place a limit. But yeah, then I guess also subject to issues about overall likelihood of making the correct judgment. And then you start to stumble back into debates over evidence-based medicine, and so on very quickly. Yeah, so I think I say yes. But
I mean, one of the things is you could argue that in most cases, I don't know about breast cancer screening, but you're not aware of the patient's value system, so you can become more accurate in the particularization if it's a very rational one. But in most cases, you're not aware of the patient's value system, so that's quite a dangerous sort of route.
You can assess that fairly quickly, and you can. It's very easy to assess from the patient how frightened they are about a particular issue.
Right.
And that does play a part in the counselling session, managing their fear, according to whether they've had every relative in their family who's had terrible metastatic breast cancer at a young age, for example, or they've never seen a case before. It does alter how the consultation is, but it's fairly easy to pick up on it, I think.
Is that their value system? I mean, he was talking about how much you would weight what you think they might want versus what they actually want. Not about them being frightened necessarily, but just purely their value system.
Well, I don't know. I mean, I think things like how frightened you are important parts of your value system. I mean, I would take it those are important considerations.
Yes, no, but you're right. Fear isn't the same as value, but surely it plays a part in the value. If they're...
Oh, sure, yeah.
But also,
I'll give an example in CBD. If you said to someone, I'm going to give you these pills, they're going to reduce your cognitive behaviour. You're going to feel slightly drowsy, and that's going to be forever. But you're going to reduce your risk by 10%. Your value system might say to yourself, I value being highly, sharp, and actually having this increased risk, this less years, and you'll make a value system. So it'd be very difficult for a doctor to. That sort of question probably wouldn't go on, certainly in primary care.
Yeah, no, that does seem right. I mean, so here's just a related a kind of related approach, which in a way is one of the places some of this work started. And it's precisely with, we do have so much evidence, so the question of fear as it relates to a kind of valuation is actually, I think, really interesting. If somebody is very scared of something, you might say it's an irrational fear. But there becomes a point where it's just the kind of person they are. It's just the way they are. And finding that gap between the irrational fear where you think it's correct or proper to sort of argue a patient out of it or to coax them out of it, and the kind of fear which really is constitutive of their values in itself and kind of deeply embedded in, say, family history or something, is, I think, very hard to tell. But I take it that on the value side, we're used to having those discussions. What's interesting is on the risk side. I think there's something funny going on where people will often say, oh, patients are very bad at reasoning about risk. And in a way it's true. But the point at which helping someone reason better about risk becomes, in some sense, unreasonable or imposing on someone. So I think far more complicated in the first instance. How the two interrelate is exactly what's bugging. I think something's back there.
Yeah, sorry, just to kind of expand on that point a bit further. I'm involved in the other end of the spectrum as an oncologist. So I deal with very different risks, speaking to people who already have the cancer outcome and talking to them about the risk of death, often the risk of recurrence, for example. So the conversation is very different, and I can feel their understanding of what that means is very important to the discussion. And what I would say is, or what I would like to raise is, I feel there are circumstances where conveying risk is actually harmful to that relationship. Often because of fear. There are frequent discussions that I have where you're asking patients what their values are or what they want to know, nothing is happening. But we are forced, through a process of things like informed consent, to inform them of risks. So it's slightly different to, perhaps it's not so different to screening, because by sending letters out, you're forcing people to know their risk. And I've definitely had people very frightened who don't want to know that their chances of responding to that chemotherapy is 1 in 5. Whereas we would deem that good enough to go ahead with treatment because it's better than a 0 in 5 chance. So I just wanted to raise the implications of explaining risk being negative.
Yeah, look, I mean, those are really, really important questions. So, I mean, what I guess I kind of am assuming in the talk in some sense is it's almost like a question-answer structure. Yeah. If someone asks you, what's my risk, what answer can you give? Of course, you're right. What two things? First, there's a separate set of issues about people who don't want to ask a question, who don't want to know the answer. I think that's really very interesting. I mean, I don't have anything useful to say about it. I guess I've been focusing on cases where, assuming you should give an answer, what answer should you give? But of course, you're completely right. There's often the question, is it better not to give an answer? Or is, if the person doesn't want to know, they aren't even asking that question. Should you proactively? And that's very interesting. I mean, I don't have anything useful in general to say. But of course, you're right. The screening program is interesting for it because it's a proactive reaching out. And of course, that's a worry about screening. So you medicalise people. They make, create the worried well and so on. And I have no useful grip on how to think about the issues in screening context, where it's done at a population level. And so how it works in a kind of individual clinical encounter like that, it just sounds very different.
There's lots of papers that say that social comparison is more powerful than the actual risk. So people spend more time, give more attention to their relative risk than their absolute risk. in a way most people don't know their absolute risk and don't know how to respond to it. But when you give them on top and lay on top of that their relative risk, they respond quite strongly.
Yeah. Yeah, the absolute relative risk is something which is floating around in the background here. Because, as I said, I see a lot of papers where somebody that says very quickly, relative risk scores are just misleading or problematic. But what's interesting is people like relative risk scores. And there's a very nice paper, I've completely forgotten which title, I must have it written down somewhere in my book, which is precisely on giving women relative risk scores for breast cancer risk and how useful they find it as a kind of, because what people are really scared about is being abnormal. They're not scared about getting breast cancer so much as they're scared of being abnormal. One thing I find very funny is it's I said very quickly in passing why people aren't rational. But of course, there's a way of constructing a rational choice model where let's just really have preferences over. They have preferences over being normal or abnormal, in which case the information is relevant. And I just think the world is so complicated that I don't know what to say. Sorry, I keep on saying I don't know what to say. I want questions.
I just wanted to take it from a completely different perspective, step out from a professional role, and take it as a patient. I've got a gallbladder polyp, which is possibly there's a small risk that it's malignant. And I've been going to clinics now for the past 2 years now. It's a wonderful thing about the NHS is you always see a different doctor. And I would say that 4 of the 6 doctors I've seen, surgeons I should add, have said, have it out. It's a terrible thing to get gallbladder cancer. No discussion of risks, of the risk that it's carcinogenic, the risk of taking it out, the risk of leaving it in according to whether it's not carcinogenic, none of that. And I've had to write and read up about it and discuss it. One of them has actually agreed with me. But, I mean, I really enjoyed the discussion this evening, but from a consumer point of view, I have to say that any real discussion of risk about having my gallbladder taken out has just not been present. And I think that's a real shame. So, yes, I mean, I have my own values and my own perceptions of risk, but they haven't really come into the equation in terms of the way the situation is being presented to me. And I suspect that for things like breast cancer, where there's a lot of discussion about it in the press and in the media, people are much more aware of the issues than for many other forms of disease.
So what did doctors say? Did you query them about the risks? Did they have the information they were giving you, or did they not have it?
No, they didn't have it. I have it now.
I mean, so like I don't know what to say about this particular institutional kind of arrangements, but I'm sure that it's interesting. It's interesting because so often in the literature I'm used to, medical ethics, it's just taken for granted what a doctor should be doing, setting out the risks, setting out the options, and so on. It becomes a patient's choice. And then, of course, all the literature is around, what about a case where the patient is incapacitated or the patient has crazy beliefs? But of course, in practice, it's not as if even the kind of basic ideal is often attained. And how one makes it the case when it happens, I just don't know. I wish I did, but that must be a question about institutional design, doctors' training, or I don't know. This is admittedly a long way from reality.
I've taught medical statistics, and it's very interesting. I've taught medical statistics, and it's very interesting with students, undergraduate students, and misconceptions and so on are there. There's no doubt about it.
I'm sure that's right. I mean, it's very funny because you do see this literature which says, you know, our patients are very bad at reasoning statistically and probabilistically. But of course, what's funny is when you look at the Cameron and Tversky studies, it's not just the patients who are bad, it's the doctors. You know, that's the part people forget. In a way, all of this is very different.
There is also the point that there are some conditions in which we really don't know what are the risks. And that's the point. Many doctors focus on the utility side, precisely because we really don't know what are the frequencies.
I'm sure that's right.
And all this tension between big statistics and individualized statistics has arisen because recently we have gathered some information. Of course, with low prevalence cancers, the uncertainty is much bigger. So maybe most of your doctors really didn't know. So they tried to
But they didn't tell me.
Well, that's another discussion. So how we doctors deal with ignorance.
Do we have another question? Or? Well, just an announcement. 2 weeks from now, same time, 2 weeks from now, same time, same place, we're going to have another colloquium, and the title is Surviving the Sirens, Should There Be Advanced Directives for Bipolar Disorder? So I hope to see you all there. Thank you all for coming, and let's thank our speakers again.